Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Mitul Patel.
Thank you, Todd, and hello everyone, and happy Tuesday. Thank you for joining us today. My name is Mitul Patel. I am the Senior Director of Market Intelligence with the American Hospital Association Center for Health Innovation. I'm humbled to serve as your moderator today. Before we jump in, a couple housekeeping notes. Just wanted to make sure you guys are mindful. First off, this webinar is being recorded. You'll receive a note from the team once this recording is made available to you. We will be holding a Q&A session at the end of our time together. So if you think of a question, please submit it via the Q&A pod, which is located just to the right of your screen there. We'll answer as many questions as you can during that Q&A time. We also have the PowerPoint located for you right under the slides. So if you want the file, you can get it there. You'll also find the audio dial-in information if you want to jump in via your phone to get a better audio connection. You'll find that information down there as well. So with the housekeeping out of the way, let's get started. It's my pleasure to introduce today's webinar, which is sponsored by our good partners, Hospital IQ. The topic is Looking Beyond Acuity, How Intelligent Automation Can Improve Daily Staffing Practices. We're delighted to be joined by Brian Dickerson, who's the Senior Director of Workforce Solutions for Hospital IQ, and also his colleague Terry Ridge, who's the Director of Clinical Solutions at Hospital IQ. So let me get out of your way and we can get things started, and I'll hand it over to Terry. Thank you, Terry.
Thank you, Mitul, for having us. Thank you, everyone, and welcome to this webinar. I'm very excited to be here with you today, and I can't thank you enough for taking the time. I do know how busy you all are. So again, my name is Terry Ridge, and I am the Director of Clinical Solutions here at Hospital IQ. I have been a nurse leader for just about 30 years, house supervisor, inpatient nursing director, and most recently, Director of Throughput at a health system outside of Chicago. So I do understand the staffing challenges that you all face on a day-to-day basis. Today we're going to talk about acuity, but beyond acuity, more importantly, we're going to talk about how technology, like an intelligent staffing solution, could actually help you drive more efficient practices. We get asked wherever we go about acuity, every hospital we visit across the country. And acuity can be a great tool for many reasons, and I believe in using acuity. It can ensure that you have equitable assignments across your units, right-sizing your staff to meet the needs of the patients, and it helps you make decisions when it comes to allocating resources. Now we know that resources are not that readily available these days, but it will help you make more efficient decisions when you do have them. But in the same sense, it can be expensive. It can also be very difficult to implement and sometimes hard to keep accurate. And everyone has a different opinion on the needs of a patient. So let's talk about some of the benefits of acute-based staffing. It's quantitative, and what I mean by that is it uses data that is directly coming from your EMR that's documented by your staff to determine the needs of the patient. It provides balanced care, so you're better able to align your staff based on what the needs are of the patient. Competency-based, so this takes into account your highly skilled nurses, which enables you to pair them with the more complex patients on their unit. Patient need-based, so it assigns based on the needs of the patient instead of using a fixed ratio or a staffing grid that we see so many hospitals still using today. But I think more important than anything is improved outcomes. So there's an overall improved quality of care for your patients, and actually an increase in your staff satisfaction. We talk to nurses on a daily basis, and we know one of the biggest dissatisfiers today is a staffing shortage and working above their staffing pattern. But acuity is just one piece of the process. It's still extremely tedious. It only represents one data point, and it's really not future focused. And what I mean by that is it's based upon the information that you have on current patients within the four walls of your facility. It creates a tremendous amount of hours per patient day challenges, as I'm sure many of you on the call can attest to, because it's only looking at a specific snapshot in time, and it's not taking into consideration changes in the census or possibly the time a nurse may need to spend on a patient or family or something that's currently going on in your unit at the time. And it really does lack that holistic view. And what I mean by that is it's not taking into consideration what's going on across the entity of your organization. For an example, patients being admitted to your facility, patients going home or possibly transferring out of your facility. So healthcare is changing, and you all live this every day. I don't have to tell you that. But I believe now more than ever, our staffing practices need to change along with the ever-changing healthcare. It needs to become not only more meaningful, but maintainable. Here at Hospital IQ, we can provide this immediate impact. And how we do that is we collect data from your existing solutions, and we provide an infrastructure that allows, for example, your charge nurses to look at what's going on their unit at a given time. They can review their current staffing for accuracy, and they can communicate to the staffing office or whomever is doing your staffing. We know that not every facility has a staffing office. It may be your house supervisor. I've seen several units that have, managers that take turns on a weekly basis doing staffing. So the ability to communicate with that person, any special needs that a patient may have. The staffing office then begins, or the designee begins to gather that information from those charge nurses, and they start to begin to formulate their float pool. And at this point, they're able to look at the data that they have received from all of the charge nurses on the units, and they start to deploy resources when available. Now, I think what's more important to take away from this is all of those steps can be done at their convenience without a phone call on a mobile device. We know that nurses are not sitting behind a computer. They are busy. Charge nurses have full patient loads. Nurse managers are now taking patients and helping out. So we want to be able to provide that information to them when it's convenient for them. There's so many times, and I've lived it myself, where I'm trying to call the charge nurses. They're busy with a patient, but I don't know that on the other line because I don't know what's going on with that charge nurse. And then the charge nurse is trying to find the time to communicate back. We provide an avenue that communication can be done seamless when it's convenient for your charge nurse without any phone calls. Because we know all those additional phone calls and the amount of time it takes to do staffing takes away from patient care, and that's what we're trying to avoid. Right now, I'm actually going to turn it over to Brian to take over the rest of the presentation.
Thank you, Terry. And I'm Brian Dickerson. I'm the Senior Director of Workforce at Hospital IQ. And I spent my entire career in software development in healthcare workforce management. So that's all I've really ever done. And when I look at the current healthcare staffing environment, I think it's probably one of the most challenging times that I've seen. And I first would like to start off by thanking all the nurses on the call for what they do and what they're having to deal with in the last year and a half or so, and the challenges and the constant curveballs that are thrown your way and so on. And what I'm hoping today is to talk through what we do and how we do things to make a difference and show you how we can even help, because I think, helping those that are providing frontline care, putting them in a better situation to be successful is extremely important to all of us. So let me first start by where we fit into the workforce management continuum. We're not a staff scheduling company. We complement staff scheduling companies. Staff scheduling companies, like Kronos and Simpler and Cerner, they're really good at generating schedules. They have all the tools for self-service and everything that's needed to create schedules. But what we found that where we needed to add some capabilities was really around the 7 days before an actual shift, really understanding what has happened since that schedule was generated, what changes have happened, what's the predicted patient volumes that are going to be coming our way, what staffing capabilities and levels do we have, and how do we put that team together so if we can, is really try to make the day of the schedule far less chaotic and less stressful than it is today. And honestly, that the staffing process really hasn't changed much in the 30 years that I've done it until what we're providing. So we're really working hard to make the solutions, just make that process easier and better align your staff to what's needed in advance. So what we specialize really is taking data and turning it into actionable intelligence. And so we're not just looking at staffing data, we're looking at all kinds of information about what's going on in your healthcare organization. What's going on in your surgical areas, what's going on in your EDs, and forecasting some of this information. We also take information from your workforce management systems, being time and attendance and your scheduling, and even information about your employees. And we marry them to what you might have for your staffing grids, or taking information directly from your acuity system. We can bring that all together and put it through a process that's going to help you understand how are you staffing today, what are what's going on in the various units, put it through a policy standardization process so that you can start to look at your entire continuum of how you're staffing and what your needs are, and look at your organization through many different lenses to see how can I share staff, how can I work to right-size staff within the next 7 days. So we push that data through a transformation process, which really yields things like the census forecast, which is a highly accurate, in the mid-90s to high 90 accuracy of what patients are you going to have in the next 7 days. We actually go out farther, but we typically just focus on the next 7 days. What patients are you're going to have, where are they going to be, and how does that align to what my staffing is? And now again, if we're using acuity, and I too do believe in acuity too, we can use the acuity in combination with the forecast to inform about the patients that we know about, and also inform about the patients that we don't know about, the ones that the acuity system isn't aware of, and where they're going to be. So we bring all that together, and we really put these into workflows that help first the charge nurses on the unit communicate to the staffing office, well, what are my needs? What are the things that have changed in the last minute? Is there any special needs of patients that may or may not be covered by an acuity system? What staff may have picked up some shifts or called in sick, or what changes have happened, maybe called in late or whatever? How do I communicate those things? And as Terry said, these are typically done today via phone calls. Very disruptive phone calls that will hit people at the least opportune time, and it's quite often there's a lot of phone tag being played. But then it creates the tools for the staffing office to use everything based upon what they've been communicated from the charge nurses, based on what they know and what the system has collected about the current state of affairs of the organization, and create their deployment plan, which is automatically then, once approved, communicated to the staff on where they're to report, basically streamlining the operations. So I'm going to go into some detail on these things, but I just wanted to kind of highlight that what we do. So there's really three areas that we focus on. Again, we talked about the charge nurses and their need to first validate that the schedules that are in the workforce management system are indeed accurate, and to communicate any changes that may have occurred to the staffing office in a really efficient and quick manner. And also document any special needs of any patients or any situations that are important for the staffing office or even leaders to know, and where they can, through the system, they can highlight information that maybe they want the leaders to see. From a staff allocation process, creating tools that makes it easy for the staffing office to see the big picture, makes it easier for the staffing office to look at the organization, if you're a large organization, to be able to look at like units across multiple hospitals, be it based on a service line where there's critical care or labor and delivery or whatever, or look at units within one hospital and see how those units may be able to work together to cover the needs of the patients at the current time. So we have that ability to basically slice up the organization by region, by service line, by campus, all kinds of different ways to look at it. Anything that makes sense to your organization where you might share staff. And then ultimately deploy that staff and communicate all that information out to the staff. But what is probably more important than even all that is provide tools for future planning. Allow the organization and its leaders to get together and look at the next 7 days and see in advance where the true problem areas are going to be and decide how to tackle those, whether it's, a manager thinking that they can handle it on their own, or do they need help from the folks pool? Do we need to look at possibly some agency labor when necessary based upon when it's really needed, or even apply incentive pay based upon when it's really needed? So it allows you to create boundaries in processes to when you need to apply premium type pay. So first we're going to talk about the patient care needs and that process of the charge nurse to go into the system. Again, it's what we have is the infrastructure that can be deployed through a mobile application that will allow the charge nurse to go in when it makes sense for them, when they maybe are waiting for a meeting to start, or maybe when they have a little bit of downtime, and actually look at what's the staffing for the next shift and what adjustments might I need to do based upon, the variances, anything going on there. So first I'm going to show you the what we call our shift editor, which is what's deployed to the staffing office. Deployed to the charge nurse. And here you can see we're highlighting an area here where the charge nurse can look into the future here and see, well, how many patients do we have? How many RNs does that require? And we're just looking at RNs here, but we can look across different scale. And that requirement can be developed or derived from either an acuity system or possibly a staffing matrices set up by the organization. And then compare it to how many RNs are in the schedule for the time period we're looking at and give a variance. So right away the charge nurse knows how they're sitting from a staffing standpoint. From this list, we can just see one name at the bottom, but they can actually look at who are the staff that's scheduled to be there at this time. They can make any adjustments to that. They can also enter in notes in this infrastructure, and the notes can be tagged, have people tagged to it, so it highlights it to them and it communicates them through their email or whatever. But also any special information through this communication infrastructure that we enable, with even things like little emojis where they can have a little fun with it. But this is very important because one of the things that we've seen with a number of our clients is that having the history of the communication to and from the staffing office to the charge nurse, you actually get a good understanding of how you got to the end game, if you will, of where you ended up with your staffing? What was the communications? Are there any misunderstandings in policy and how staffing works? One of the things when I talked about standardization, we find a lot is just getting people on the same page on whether or not, you know, your charge nurses are counted in patient care, or if you need an ECMO nurse, how that affects your staffing, whether or not they're going to be included in your numbers or not. So by tracking that history, it really helps standardize and make things easier in the long run. We have the ability here where if the charge nurses know that you have a patient that's going to require a one-to-one, that may come again from the acuity system, or that may be coming by just a charge nurse going in and assigning a patient load of 1 to a particular nurse's schedule, which then tells our system that, hey, readjust your staffing needs because this nurse is only going to be able to take care of one patient, and now we're going to have to make some adjustments and show that to the staffing office. So that's easily done through the system. We can also track call-offs, which is something that seems to be a little bit of a challenge. And so if there is a call-in, a nurse that called in sick, the charge nurse can go in real quickly and remove that shift and put a note in there and track that through the system. And we have a reporting infrastructure that really helps with that. And then lastly, I talked about the ability to communicate in the notes that are put in the system. And again, this is very important and something that was lacking, and we find that almost every organization we go into, the communications from the staffing office to the floor, to the unit, to the charge nurse is done by phone, by text, even fax. I've seen that happen where they're faxing information across the organization to get to the staffing office so they have a good understanding. We automate all that, collect that information, and it's there forever then from a historical standpoint. So then once we gather all that information from the charge nurse and we have a good understanding of what's going on the unit and what's expected for the next shift, and again, the charge nurse is looking at the forecasting tools, but we then turn it back over to the staffing office where they can now look at information, all the information they've collected from the charge nurse, and a series of information about the staff and their capabilities that they can then use to determine how am I going to balance the organization the best I can considering the circumstances that I face. And we all know in healthcare staffing, every day, every 4 hours, the whole playing field has changed, and it's a different ball game that we have to figure out how we're dealing with, how we're going to deal with it. So first here, I'd just like to highlight some of the information that we make available to the staffing office. First thing is what we're looking at, how many units we're looking at, what's the view that I'm looking at. Am I looking at a particular hospital? Am I looking at a service line across hospitals? Am I looking at a service line across hospitals in a particular region? However your organization operates and how you need to look at things so that when you're making your staffing decisions, you're looking at what's appropriate. We even have different float pools and can help you organize into different float pools based upon what areas the float pools cover, whether it's in a regional float pool that may cover a wider range, or it's a local float pool that's just for a particular hospital, or float pools that are specialized on service line, whether it be ICUs or med-surg and so on. We collect information about the associates and what they can and can't do and where they've worked before. So if you're looking at, who you might be able to float, have they actually worked in a particular area before? So do they have that? And we can also look at the skills, but we also can kind of create our plan of who can work where as things happen. So sometimes the skills aren't tracked as well as they could in some organizations, so they're not readily available for us, so we actually build them as we go. We have information that will tell us if we had to stretch our staffs. We have a multi-leveling system that allows you to take look at your organization by adjusting your ratios slightly and incrementally, so you can see, well, I typically run at a 5-to-1 ratio on a med-surg unit. I'm not going to have enough staff to cover the patients I have. Unfortunately, this happens. But what if I ran at a 5.5 RN to patient or patient to RN ratio? What would it look like there? Will that allow me the flexibility to figure out? And then I can stretch the staff with some equity across the units versus doing it without a infrastructure to help, which sometimes creates the perception of, the reception of favoritism. We track information about the orientees. How many shifts have they worked? If you have a situation where you're short-staffed, but you might have an orientee that's worked 20 shifts, well, that might help you make a decision, especially if you're trying to figure out how to deploy the float pool and you don't quite have enough resources. How do you know if you have staff members that can't cover COVID or airborne disease shifts, and whether or not you can deploy them? So we have all that information, and it's all being collected behind the scenes and made available to the staffing office. So once the staffing office gets this, some of the information, there's additional information here available. If we're integrating with acuity system, we can display at the unit level what's the acuity across in the various units. And why that's important is sometimes if you're deploying a float pool or deploying some resources, and you have one staff member left and 2 units that need them, you can look at information about, well, does this unit have higher acuity in general? So that may be the tiebreaker of who can do that. The other thing is we grab and we pull from orders the discharges that are in process, and we have a full discharge management piece of software too. But if that's not available, we'll just pull the, what are the active orders on the units, and understanding that, rollover and churn for discharges does add workload. You can see that when making the staffing decisions. We also look at patient-level indicators and can do adjustments on the staff needed based upon things like level of care. Quite often we see that there may be some progressive care patients on an ICU. Well, if there's enough of them, you might be able to get away with one less nurse on the ICU unit because you can run at a higher ratio for the progressive care patients. So if you have situations where you have overflow across service lines, we actually bring that in and we can automatically calculate that. So we have this explainer here that shows, well, we're telling you need X number of RNs, here's how we calculated it. We calculated that we need 2 RNs because of the patients you have on a different level of care. So many of them are from the staffing matrices, and then also if there's an acuity system involved, we use that information too. And we can automate the float process to be able to actually just press a button and let the system figure out how am I going to deploy staff across the departments that you've selected. And it takes all this information into consideration, and it looks at the history of where people worked. And also we track the last time somebody has had to float. So if you need to move somebody from their core unit, it will take information about, who's the person who floated last and who's the one that hasn't floated for a long time, and take that information into account. So we bring all that together. We can simply automate this process to make it easy, providing the staffing office wants to do that. So that can be done. And what we found is that we've streamlined the process of deploying staff, the communications process from the staffing office to the units, which saves time for your charge nurses, which we really prefer having them spending more time with the patients and their team, and also streamlining the process of the staffing office, which allows them to get their float plan out sooner, which is beneficial to the unit too, because if you know who you're getting, if you're getting some float resources or whatever, you have a better, more time to figure out what your patient assignments are going to be and so on. So it's very important to get to create those efficiencies. The other thing we find is that by creating efficiencies in the staffing office, we actually use the staffing office time save to help the organization become more proactive, and I'll talk a little bit more about that in a bit. So lastly is resource deployment with the system, and again, this is about deploying the staff and communicating to the units and to the staff that are being float where they're going to be working. So what we have is a concept of a sandbox and the ability to unlock shifts, where the staffing office can go into the system, deploy their staff, but it's really not known to anybody. And in most of our organizations, when the staffing office gets their plan established, the last thing they do is have a quick call with the house supervisors at the various hospitals just to review that plan to make sure that the house supervisors are in sync with what they're going to do, and have some say into who may have not gotten resources or who did receive resources. But once that they get that approval from the house supervisors, they simply click on and unlock the shift, which then releases that information to the units to see who they're getting, but also sends and through a note here, which I have, so it sends a message out to the units. And it also sends a message to the staff with, okay, here's where you're to report today. So, and we found that was another time-consuming process, which in a lot of organizations, as soon as the float assignments were made, the staffing office spent an hour plus either calling the team that's working or scheduled to work today, or taking the calls from that team on where they're to report. So we've automated all that. And again, the time savings is really intended to go back to patient care in the case of the charge nurse, or have the staffing office assist the organization becoming more proactive. So the next process is really the future planning piece, which is intended to make the day of staffing much better. And this is where the forecast really comes into play. From the daily staffing, when you're really working on the next shift, we're still looking at the forecasted volumes over usually in 4-hour increments. So my next 12 hours or 24 hours, how does my staffing look based upon what's the forecasted volume of patients? So you can have that when you're making your staffing plan. But the future staffing plan is really a process of looking at the next 7 days, which is typically done by on a weekly basis, the unit leaders getting together, looking at a view that helps them understand, well, which units are going to be short on which time periods, depending on how you want to look at it, and do the unit have a plan of attack? Do they feel they can deal with it on their own by having people that want to pick up extra shifts or whatever, or is it possible for the float pool to help out? Does the float pool itself need to have some schedule adjustments from days to maybe move some staff to be able to help days when they're short? Or does the units need to move their staff around? Like, do they have opportunities where they may be better off on one day where they can ask some people to move from day to day, which really helps us see that in advance, and by giving more time to the staff, if they have to organize childcare or do whatever, that gives them the time to make those adjustments. So by having this process in place, it really helps that unit leaders see where their challenges are, the staffing office and the group of them see what's coming their way and what do they need to adjust from a flow pool standpoint, or maybe apply incentive pays or whatever, and really put a process around that to make sure that if you're going to spend extra money, you really need to. If you're going to float your team members to a non-home unit, did you really need to? And make sure that you're driving the value drivers, which is all about how do I make my staff happier? How do I minimize the amount of pay that I'm throwing around? Obviously, in today's world, that's easier said than done, but it's still, you do get savings here. So in this view here, this is a very simple view. It's showing us the next 7 days in a variance-only view in a heat map, which allows, based on a group of cost centers, to look at where are my big challenges. Now, there's a lot of red in this view. Unfortunately, there's a lot of red in most of our clients' views because they're typically quite short. Again, we have the ability to say, okay, what if we run it a little bit higher ratios? How does that make it look? We can do some simulation there so we can show the organization, well, if you ran at a level 2, which is a slightly higher, this is how your staffing would be, and so on. Doesn't mean that it creates more staff. I wish I could do that for everybody, but it just helps balance that stretching, if you will. One thing that's also on this view, and I forgot to mention it previously, is we do track boarding in the ED, and quite often, so we're actually tracking it and forecasting. So if your ED is boarding or holding patients because there's no room for them in the units, we make that available in advance so that adjustments can be made, because quite often the staffing office has to cover that. There has to be nurses allocated to the ED to be able to cover those patients that are waiting for beds. So that's included in this, so that you can see that information and see that into the future, 7 days out. So the whole idea here is again, the group of managers that make sense to work together, that make sense, that can help each other out, along with the float pool, get together on a weekly basis. They look at this view and they decide how they're going to attack their problems, and they do that in a very structured and organized way so that it's not last minute, and they use the forecasted variance of where they're going to be short or where they may have extra staff to move things around and basically try to fit the puzzle together, so that when it comes to the actual day of staffing, things are much better. So when you think about this digital transformation, that is achieved, and I'll go over some metrics from our clients, but our goals are really to change how we do staffing from a very unit-focused, fragmented world. Even if your organization doesn't have a staffing office, we work with smaller organizations, and every one of you have people that are actually still kind of the front person, or I call them the air traffic controller of how we're organizing the organization. So this tool really helps them. But really looking at the organization as a whole, we can't afford in this world to look at things in a siloed cost center or unit level view. We have to look at the big picture and see what we can do to move staff and try to put the staff in the best situation to provide the best care possible. We're transforming the organization from being a reactive, which honestly the nurse leaders and nurses and the staffing offices have gotten very good at, and very innovative on a way of reacting to what hits them, but really helping them to be more proactive, be more collaborative, and then create a layer of transparency so you have that ability to see the discussions, what's happened, how did you come to your decisions, and how can everybody across the organization, where needed, see how the staff have been deployed, which is very important. In most of our organizations we work with, all the managers have the ability to see the bigger picture and how staff was deployed, and can go look at some of the notes and things and see what's going on there. We don't go down and lower, because that sometimes can create some friction. But the managers, it's expected that they're looking at it from a team-oriented aspect. So some client impact examples here. Some things that Health First organization we were able to accomplish: reducing core floating outside of primary cost centers by 29%. That's pretty big, and that's a staff satisfier. But we actually, we also tracked how much we floated staff outside of the service line, and that was a much bigger improvement, where you're putting people maybe in an ICU down on a med-surg unit, which we really don't want to do. We cut back 45 minutes of communication time on daily staffing planning. That was time from the staffing office that they did not need. That was time that we were able to deploy the float plans faster because that communications was streamlined. We eliminated 500 plus calls on a monthly basis. So that's 500 times the staffing office was calling to and from or getting calls from a charge nurse. And as you know, calls you don't know when you call somebody if that call is being placed at a time which is most conducive or least disruptive to the person you're calling. So those calls, not having those calls has really helped that charge nurse really focus on what they should be focusing on, which is patients and building their team. At Mercy One, we reduced the premium pay by 50%. So their existing premium pay utilization was cut back by 15% by putting the boundaries around when we applied incentive pay and when people were and what incentive pays were being applied. Now, obviously, COVID has thrown some curveballs into that, and most organizations now, incentive pay is being used quite heavily because of the shortages. But it's still, you have to have boundaries around it and understand when you need to use it. 80 plus hours given back to the staffing office. That was the number of hours on a weekly basis that the staffing office was given back, that they are now deploying and helping the organization be more proactive. So today at Mercy, the staffing office, when they get done doing their work, they're looking into the future. They're helping the organization see where there are opportunities and help the managers, understand what they can do and help them, teach them what they need to do there. And then this one I think is probably the most important one, and this is 10 plus hours giving back to the nursing leader to focus on patient care. So when we started working with them, the amount of time that they were spending, unit manager was spending in staffing, we reduced it by 10 hours a week. And that's like 25% of that manager's time, providing they work only 40 hours, that they can now be used. And I interviewed one of the managers, and what she told me was, I can spend it with my team, helping them, making sure that they have what they need to provide the best care they can, and I can also spend time with my clients, making sure that if they ever need health care again, they're coming back to our organization. That's extremely important, and that 10 hours to me is one of the key things that I'm proud about what we're able to deliver, because at the end of the day, everybody will need health care, and if we know that the managers are using tools that give them the most time to spend with their team and their patients, that's obviously an organization that I would want my grandkids to be in. So in conclusion here, when you think about using a solution that can consume acuity information and can consume a lot more information and present it to the users in a way that makes their job more efficient, easier, and taking less time, because again, I think less time is an extremely important thing. That drives value to the staff by helping them being better positioned for providing care. For the staff that are leaders and for the staff in the staffing office, taking away time that is really non-value add and transitioning their role to driving better outcomes. From the patients, the faster the staff is aligned to what's needed to their needs, and the better the staff is aligned to the patients that are there. Obviously, that improves patient care. And then from an enterprise standpoint, having the ability to look at your organization through many different lenses and see the information about your staff, your teams, and presenting it in a way to make it easy to work with is very valuable and drives down costs, but also makes sure that you're allocating your resources based upon the situation in the most efficient way and the way that's going to get the best care that you can. considering all the curveballs thrown at you. So I think for that, we're about ready for Q&A, and I'm about ready to lose my voice.
well, Brian and Carrie, thank you so much for that detailed walkthrough. Absolutely a very urgent and acute challenge that the field is dealing with on a day-to-day basis. So thank you for that. Yeah, let's jump right into the Q&A. Hopefully you guys got a chance to catch your breath and get some water. Our first question, just as a reminder to the audience, if you do have a question, you do see the Q&A panel on the right-hand side of your screen. If you type it in there, it's still not too late to get your questions in, so do let us know what's on your mind. Our first question is around implementation. Help us understand the typical time frame of a system like this to get implemented.
Well, we actually implement these things pretty quick. We can do them within 3 months. I will be honest that we need to get some data, and that usually is our challenge. But really, the implementation on the nurses, the charge nurses, and the staffing office is relatively easy. And we made it as light as possible and as easy as possible on purpose, because your team don't need more work. We really spent a lot of time designing a system that's what you need, just what you need, easy to use, and go that. So typically it's about 3 months. Delays are usually pulling the data, but 3 months we've had it, and we just did an install in 3 months and had them up and running a little bit even sooner than that. So we can go pretty fast.
Great, thank you, Brian. Our next question is more about what gets factored into the matching of patient care acuity and needs. So how is, for example, staff competency assessments, clinical ladder level, those types of factors integrated and incorporated into the matching?
I think I can take part of this, Brian.
Okay, sure.
So I think Brian had showed you that we have some facilities currently, they want to know who their ECMO staff, trained staff are. So there's a place in the software that you can actually put that information, so when you're making those decisions, you have it readily available that you can see. Same with a clinical ladder. If you're using some type of clinical ladder leveling system, if you have a level 3 nurse, like I mentioned, you can start to pair that with your more complex patients on your unit.
Got it. Our next question is around, just the balance of using agency staff versus regular staff. How do you ensure or maintain that regular staff engagement and satisfaction while balancing the use and leverage of agency nurses who might be extremely expensive relative to that regular staff?
Well, it starts by making sure you're only using the agency staff when you really need to. So you have to be able to look at the future and look to see, what are your opportunities. So when you look at the future planning view that I showed, you can see where you might have opportunities to use your existing staff better and limit how often you use an agency. And then also looking at where you're going to need to be floating people, use the agency staff for that. Try to minimize the time you're floating your core staff, because that is a dissatisfier. So by only using the agency when it's truly needed, based upon the forecasted problem areas, and using your staff as much as possible in their home workload, you actually create a better environment for your core staff.
And just in addition to that, Brian and I both have the opportunity to sit on staffing calls with some of our clients, and they do pull up the 7-day forecast, and they have this discussion. All of the managers are discussing on one Zoom call as they're all looking at the same thing, and they're discussing how they're going to share and how they're going to look at their own unit first and know where they're going to be in a few days from now, and start to look at sharing that staff. And like Brian said, when you start to be a little bit more proactive in your planning with your staffing, the goal is that you wouldn't be using as much agency because you know what's coming and you have the time to plan for that. You're not just doing it 2 hours before your shift is supposed to be starting.
Right, right. We have a question with some of our smaller members and organizations, critical access hospitals. How does your solution work there? I mean, the question that's here is we lack a staffing office and typically rely on a charge nurse to ensure staffing for the next shift. So help us understand how it might work for a smaller organization like a critical access hospital that might not have that staffing office.
Yeah, in those cases, there's usually one manager that kind of helps kind of be the somebody. If you have a float team, somebody's managing the float team. But what we've designed is for the smaller organizations more portable tools for either a house supervisor or whomever that air traffic controller staffing is to walk around with. And you need to still have the forecast to understand what's going your way, but because you may be limited to 4 or 5 units, having a view on an iPad where you can see what's going on from a patient standpoint, where is the staff right now, and right from that view do your allocations. What we see is a lot of times in those smaller hospitals, somebody's walking around with a master sheet of paper that they printed out and they're making notes on it. We come in and we eliminate that sheet of paper and we make, everybody, by providing the tools for that house supervisor or charge nurse, whoever it may be, to interact with the system on the fly, then others have access immediately to where has the staff been deployed. So it's really using the same infrastructure, but it's more about, it's less about somebody sitting at a desk doing the staffing and more about somebody on the fly out on the unit that needs to do it as an end part of their job. So we have the tools for that.
Right, and we know that, staff, charge nurses, they get called throughout the day regarding staffing issues, and you may be in a room fully garbed in isolation, and you take the call, but once you leave, you get pulled away to do something else. And I know I've been guilty of that in the past and completely forget to either take someone off of the staff for the next shift because they called in sick. So just having that transparent view and being able to do it when it's convenient in the moment and really getting rid of that manual piece of paper because it's so outdated, and we do see a lot of mistakes that are made with that. But just to add to, we don't work with just large hospitals that have staffing offices. Everybody, like Brian had mentioned and like I have mentioned, everybody has someone that's doing staffing. It may be someone in your nursing office that has that responsibility. A lot of hospitals across the country are still using their house supervisors to do that. So you don't have to be a large hospital to be able to benefit from our software, because we know even small critical access hospitals still struggle with staffing issues today.
Yeah, thank you for that response. I have a question here on just gardening buyership within the organization. So how do you make the case to senior leadership that we really need, this is a significant pain point, we need this, solution to help?
Well, I think first that you have to, obviously I think everybody understands, but labor is typically 60% of the operating cost of a hospital, and nursing is a large chunk of that. So the cost of labor and your cost of turnover, it's not uncommon for an organization to have 25% turnover of RNs, which is mind-boggling. I think the industry average is 16 or 17%. And I think the other thing is that the amount of nurses that leave nursing, I think it's 33% of college grads leave nursing within 2 years. So there's a huge issue of doing your best with your staff and trying to put them in the best position and keep them where they're most comfortable that you need to explain. Again, I think I look at the challenge of nursing today and the shortage of nursing across the country, And I talked to organizations that never had challenges before because of where they're located, and they now have challenges, and it's quite scary. So making sure they understand that this is a big cost. Our turnover is costing us a ton of money. We're right now flying somewhat blind, and we don't have tools based on data to help us see where we need to go. And that we have to get into the modern world. And so I would really go down that path and help them understand that there is substantial cost. This is a big issue for the organization. And, you know, and patient care is number one. Anything to add on that, Terry?
No, I completely agree with everything you said on that one, Brian. I mean, we talk to nursing, we talk with financial people. Turnover is a problem, and it's not getting any better. So what do we need to do to decrease that turnover? We talk to hospitals who are at 30% who are, you know, calling us saying, you know, we need some help. We need to keep our nurses, and we have to keep them happy. So those are some of the discussions that we have with some of our potential clients.
Great. I think we might have time for a couple more questions. Our next one is around use cases for the platform. You described this mainly for nursing, but can you apply the solution to other disciplines, providers, ancillary services?
For the most part, we've done all our work around nurses, but technically, yes. And it's really based upon what the data is we're going to use to forecast and how we do that. So, you know, if we're able to forecast, you know, what their drivers are for variable staffing, we certainly can plug them into our algorithms and do that. We focused on nursing because it's the biggest challenge right now, but we certainly will be expanding.
Great. And we'll wrap up with one question just on the application here. So how does the Acuity system integrate for staffing decisions relative to churn in the unit? So admissions, discharges, transferring, returning post-op patients, et cetera.
I would answer that in two ways. First one, again, we're not an Acuity system. We use Acuity data as part of the data that we want to bring to bear to help decision making. Most Acuity systems, or the good ones, actually factor in ADT information as far as what the known discharges are, and they will factor that into the RN time based upon the complexity of the patient discharge education. So that may be factored in there. But if that's not factored in there, we are also trapping and forecasting the ADT in our system. So if we know that, and I think I showed that in one of my screens, if we know that there's X number of discharges, you know, that is brought to the attention of the staffing office. So I think there's a two-way there. If it's incorporated in the Acuity, it's good. If it's not, then we can do it. But even with Acuity, it's only going to tell you about the known patients, so we're going to show you what's expected in advance.
Thanks, Brian. I'm going to try and squeeze in one more question. I'm looking at the clock here. Hopefully you have a concise response for us. There's another question. Is the program linked or integrated with the payroll system?
The only time we're linked with a payroll system, usually we're connected to the scheduling and time and attendance system, but sometimes we get information about the workforce from the scheduling system, where there are some of their credentials, you know, some of their demographic information and stuff like that. I would love to understand a little bit more about what they're thinking about from the question in some time.
Sure. Hopefully that's something we can take offline. I know we're just at about time, and Todd, I'm sure you have some closing remarks for us, so we'll turn it over back to you.
Thank you. This concludes today's webinar. Thank you for your participation. You may disconnect your phone lines, log off the webinar, and have a great day.